Good evening and welcome everyone. I'm Tony Bernardo, Dean of UCLA Anderson, and I'd like to welcome you to this year's Innovate Conference hosted by the Easton Center for Technology Management at UCLA Anderson. Each year, this event brings together successful entrepreneurs and executives for a glimpse of the latest innovations and their potential impacts. This year, we hope to understand better the most recent developments with technologies like AI and 5G, the specific areas of product or service innovation with these technologies, and the leadership thread that weaves everything together. Overall, though, our aim is to highlight the key trends in leadership today, the transformative effects of technology in almost every sector, the imperative for interdisciplinary collaboration, and the critical need for businesses of all types to serve society. We also want to issue a leadership call to action to work to understand society's greatest problems, to identify solutions, to provide organizations with an appropriate level of resources, and ultimately to lead in a way that creates value for all stakeholders, shareholders, customers, employees, and society. Technology is pervasive across industries today, with nearly every sector and job affected by tech, from financial services to media to agriculture to retail, from marketing to finance to product development to HR. This is reflected in our own MBA students' recruitment statistics, with more than 30% of Anderson graduates entering the tech industry. Now more than ever, it's essential for our students, faculty, and alumni to be well-versed and committed to innovation in sectors ranging from e-commerce to healthcare. And the events of the past year related to the pandemic, to the movement for racial justice, to the recent events at our nation's capital, and many more, underline the important impact technology can have, the responsibility that leaders have to ensure that technology is developed and deployed wisely, and the imperative that the interests of all stakeholders be properly assessed, whether they are customers, shareholders, employees, our communities, or the public at large. As you listen to our speakers this evening and tomorrow, I hope you engage with this program, learn from it, and that it stimulates all of you about innovative opportunities that can be transformative in our society. Now I'd like to introduce Terry Kramer, Faculty Director of the UCLA Anderson Easton Technology Management Center, who will be kicking off this evening's program. Terry?
Tony, big thank you. Thanks for the introduction, and thanks for your support of the Easton Center and the conference itself. And thanks for your focus around leadership and leadership in what is more and more an increasingly connected world, connected across domains, connected across geographies, connected across disciplines, and between business and society. And let me just add my own welcome to all of you and say thank you for being part of Innovate 2021. This is our flagship conference on everything tech, consumer tech, enterprise tech, everything tech. And tech, as Tony has mentioned, is part of all of our lives. It's changing our lives, our work. It's created opportunities and challenges, both for established enterprises and for new ventures, and also more broadly for society. And tech affects almost every sector today: healthcare, transportation, financial services, retail, etc. Now, in developing this conference, which is going to be again tonight and tomorrow morning, we had three goals in mind. The first one is to understand what is going on with all of the enabling technologies, whether that be artificial intelligence, cloud computing, high-speed mobile networks, the Internet of Things. What is their capability? What is their level of maturity? The second piece is to understand the specific product and service innovation that's coming from those technologies. And we're going to use several sectors and do deep dives to better understand those product and service innovations in healthcare, in e-commerce, in transportation, and in robotics. The third goal that we've got is to look at that horizontal leadership thread that weaves all of this together. The ability for leaders to think about where is innovation likely to occur? What are the enablers for the success, including customer adoption? How to think about what it takes to compete effectively in areas of innovation, how to engage stakeholders, how to think about the trade-offs, balancing what are a growingly changing and diverse set of needs. So I hope you'll find that tonight's conference, tomorrow morning's conference, gives you a better sense of technology, innovation, and broadly leadership. Now you'll see that tonight we have a keynote fireside address from Sachin Jain, who's the president and CEO of Scan Group and Health Plan. That's going to be followed by a networking session that'll bring together students, alumni, UCLA affiliates, and the broader community. And this breakout session is a first ever for us with our conferences, our own effort at Innovation, to try and allow an opportunity after the speaker to dive deeper into key issues, understand them better, to create better linkages between people at the conference, and build a stronger sense of community amongst UCLA Anderson, amongst the broader UCLA community, and across society more broadly. Tomorrow morning, we'll have a keynote fireside chat with Nan Bowden. She's the COO of X, which is formerly Google X, and that will be followed by panels on healthcare and e-commerce. So I hope you enjoy all of this. And again, we'll have breakouts after tomorrow's session as well. So let me now shift over to the keynote address on the topic of the future of healthcare and a little bit of context on healthcare. Let me start out first of all with a study that was done by the Journal for the American Medical Association that said that the US spends about twice that of 10 other high-income countries in healthcare, and that's driven by the costs of labor, of goods, of administrative costs. Same story in pharmaceutical drug costs, those costing about 4 times more than other countries. And when you look at healthcare providers themselves, you see in large part due to COVID-19, a challenge in their environment. According to a recent study by Kaufman Hall that surveyed about 900 hospitals, the median hospital operating margin has fallen by about 19% from January to October compared to the previous year. The cessation of elective surgery and a notable decline in provider visits has been a big cause of this decline. On top of all this rapid innovation and focus on COVID-19, there are many other health-related issues that have to be addressed. The cost of healthcare continues to rise. More elderly patients need remote treatment, and mental health, substance abuse, and obesity issues are all rising concerns. Developments in digital therapeutics, wearable sensors, analytics, behavioral science, all of these things can help some of these problems. This brings us all to the fascinating role of innovation and what does innovation look like in this context, specifically in healthcare. We couldn't have a better speaker for this topic than Sachin Jain, President and CEO of Senior Care Action Network Group and Health Plan, a not-for-profit Medicare Advantage health maintenance organization that provides integrated, community-based, affordable support and services for the elderly. Sachin is not only incredibly accomplished, but is also extremely well-rounded, that he's worked in clinical medicine, he's worked in academia, in government, and in big pharma. Prior to his current role, he was the president and CEO of CareMore Health, an integrated health plan and care delivery system for Medicare and Medicaid patients, and Aspire Health, one of the US's largest non-hospice, community-based palliative care provider. Both of these companies are subsidiaries of Anthem. At Anthem, he's overseen the growth and diversification and innovation in these companies, helping it serve more than 180,000 patients in 32 states with $1.6 billion in revenues. Under his leadership, CareMore built and scaled industry-leading programs to address loneliness, deliver hospital and primary care at home, and address the clinical needs of the highest risk, highest need patients. Before all of that, he was a senior advisor to the administrator for the Centers for Medicare and Medicaid Services in the Department of Health and Human Services. He was a part of the founding team of the Center at Medicare and Medical Innovation, where he managed many key innovation initiatives. He's been also the Chief Medical Information and Innovation Officer at Merck, where he led enterprise-wide global strategy on health information technology and clinical innovation. If that wasn't enough, he's been adjunct professor of medicine at Stanford School of Medicine. He serves on the board of Make-A-Wish Foundation. He has over 100 peer-reviewed articles in journals such as the New England Journal of Medicine, the Journal for the American Medical Association, and Health Affairs. He holds a BA, MD, and MBA, all from Harvard. Now, in terms of the format, I'm going to ask Sachin a series of questions that gets a better understanding of his views and his recommendations, and then we'll use Slido for a moderated Q&A. For those of you that happen to use Slido, just go to slido.com, SLIDO.com, and then enter the event code HEALTH. And from there, you can either enter in your own question or upvote an existing question. And I'll endeavor to ask the most popular questions. So Sachin, a huge welcome to you. It's great to have you here with us.
It's awesome to be here, Terry. Thanks so much for having me tonight.
Absolutely. And I have to start with your leadership experiences. You've had a fascinating career. You've succeeded through a lot of different environments in government, in academia, in industry, et cetera. Tell us about your leadership journey and what your secret sauce was.
So what I'll say is don't believe someone's bio when it's presented on stage, because oftentimes it's bumpier than it sounds. And the reality is I've been fortunate to have had a number of opportunities and had great mentors along the way who've kind of pointed me in the right direction. But a lot of my career is kind of just giving myself the opportunity to take chances, take risks. And if there's one thing I would encourage, your current MBA students is to not get locked into a view of yourself that probably, started to form when you were writing your personal statements. The world is far more interesting than your personal statement probably is. So if I asked myself what I would be doing at this stage of my life, when I was starting medical school, I thought I would be a health services researcher in Boston, be writing articles and papers and hopefully influencing US public policy. And, largely because I was able to kind of just go where the wind took me in certain situations, I've ended up in a place where I've been privileged to have the opportunities that I've had. So I'm really thrilled to be here and looking forward to the conversation tonight.
Excellent. Well, let me then start at a macro level on the industry. I shared a bunch of statistics about healthcare and costs, et cetera. What is your view about the state of healthcare today in the US, good, bad, and indifferent?
Healthcare is big business, Terry. And at the end of the day, one of the things that we haven't really acknowledged or really sought to fix is the fact that people make money when Americans are sick. When you have a fee-for-service healthcare system that ends up paying more for complicated surgeries, paying more for long hospitalizations, paying more when you need medicines when your diseases progress, you ultimately end up in a position where everyone profits when people are sicker. And we have to think differently about how we pay for healthcare in this country. And there's lots of folks who talk about value-based payment, lots of academics who write about value-based payment. But at the end of the day, we need to get to a place where we're aligning incentives more, where organizations are kind of more incented around keeping people healthy rather than actually, rewarded when they're sick. When I'm looking out my window right now in the direction of UCLA, when UCLA's hospital is full, the CFO is happier than when it's empty. And we have to change that dynamic. We have to get to a place where when the hospital is empty, we're actually celebrating the fact that people don't need our services. And that's the unfortunate kind of reality of how the business of healthcare has been structured in this country. We've built an industry where when you have a wound, you get paid more. When you need dialysis, you get paid more. Those are bad outcomes, yet the business folks who lead healthcare and lead organizations like mine, in fee-for-service payment models end up doing better than when they actually keep people healthier. And so again, that is the fundamental defect of American medicine. $1 in $5 of our GDP as a nation are healthcare dollars. In every congressional district, it's the healthcare organizations that are the most significant employers and oftentimes most influential employers. And so we're running an economy that is actually rewarded when people are actually sicker. And I think those are the challenges that we have to start to think about and ask these hard questions about how am I making money when people are sicker, and start to think differently about our businesses.
So when you look at business model innovation in relation to technology-based innovation, is it fair to say that if you have kind of a hierarchy here, business model innovation, the incentives that get created, et cetera, is actually an even bigger issue than injecting technology-based innovation to improve healthcare?
So in almost every other industry, technology gets adopted because it drives lower costs and better quality. I was part of the federal team in the Obama administration that implemented the HITECH Act, which was the provision of the Recovery Act that actually paid doctors and hospitals subsidies to adopt electronic health records. This is a big problem. This is a big problem when it literally requires an act of Congress for a group of professionals who would otherwise deliver higher quality care through the use of technology are not adopting it. Because the business model doesn't support it, because ultimately the technology made healthcare organizations slower, and in many cases actually didn't deliver on its promise of improving quality of care. We have to find a way to get to business models where we're incented to adopt digital tools and technologies, both on the boring things around the transactions that happen in healthcare, as well as the kind of sexier, more interesting things as it relates to improving self-management, improving chronic disease management, remote patient monitoring, all those other things that I think we oftentimes think of when we think about digital health innovation. I've been around this field long enough to know that the ideas are not new. Ultimately, what I think is different about kind of these different phases of the last 15 or 20 years is actually more the macro environment and what it's actually allowing people to do. And COVID-19 has had this amazing effect of actually, I think, driving 30 years of progress in the digitization of healthcare in the course of 6 or 8 months. And it's largely not been a failure of our technological capabilities, because we've always had these technological capabilities. It's really been a failure of the fact that payers like CMS or Anthem or United or Humana or Scan didn't necessarily pay doctors parity to actually see patients digitally or virtually. And so as a result, you had a world in which you literally took sick people, grandmothers, people who were 80 plus who had mobility concerns, and actually made them come into doctor's offices for low value 5 or 7 minute visits just so that people could get paid. That's the world we were in before. And now, because of this, horrible pandemic, everyone took a big step back and said, did we really need to make grandma come in? Did we really need to make lots of grandmas come in and subject themselves to the infectious diseases that they all had? And so, again, I think the job now for those of us who are in positions of influence in the healthcare industry is to say no more, right? And to actually use this crisis to begin to really transition our system in ways that are going to make a difference for patients and families.
Yeah, and is your view is that will likely happen in a reasonable period of time, or this is still so radical, the idea of pay for service and shifting it over, that's going to be tough to happen near term?
Well, I think there are areas where it's happening. The industry that I'm a part of, Medicare Advantage, senior care, private insurance companies that actually deliver on the Medicare program. We've been accelerating the spread of value-based payment. I would say 90% of scans patients are actually in fully delegated risk-based agreements with healthcare provider organizations, which means we write them a check and we say, take care of our patients. These are the things you have to do for our patients. And any savings you have in healthcare utilization is actually margin for you. And, surprise, surprise, in a pandemic when people aren't using a lot of healthcare services, those organizations did remarkably well. And so, again, I think organizations are now seeing that there's value in being in these risk-based, globally capitated payment arrangements, because it actually does create the incentives around digital innovation. Everything has to have an ROI, and you get paid up front. One of the places we're now thinking about applying this, and I really loved what the dean said about solving the biggest problems, is we're now looking at how we can apply value-based payment to serve individuals experiencing homelessness. Because if you actually look at that population, what do? When they get sick, we pay for a $30,000 or $40,000 hospitalization, but we're not going to pay for the upstream management of their chronic conditions, whether it's their diabetes, their heart failure, their mental illness, their addiction. We're not doing those things. So we're starting to think about how we can apply the principles of value-based payment to build a model of homeless healthcare, which is obviously very relevant in this city, and frankly, create momentum to actually solve this big problem that I think ails our society, this embarrassing stain on our society, really.
Yeah, absolutely. So tell us about Scan Health. Tell us about the business, the priorities, and then tell us about this idea of business model innovation and where technology fits in there.
Yeah, no, absolutely. Scan's an amazing organization. It was founded in 1977 by a group of 12 community activists. We call them the 12 Angry Seniors. This was a racially and gender diverse group of seniors who said they didn't want to age the way America was actually aging people. They said, ultimately, the status quo around aging was you get sick and you go to a nursing home. And they wanted an organization that was going to help them age in place. And so they started this group, Senior Care Action Network, very community-based. And then they were ultimately one of the first CMS demonstration project sites for what was called a social HMO. These days, it's very popular to talk about the social determinants of health, things like transportation, food, housing as being drivers of health. But this was a group of visionary people who, in the late 70s and early 80s, were thinking about just these concepts and actually led a demonstration that lasted for almost 2 decades around demonstrating whether those things could actually make a difference in improving the health and well-being of patients. They ultimately sunset that program at CMS and transitioned Scan into what is called a Medicare Advantage plan, which is a largely an HMO, privately administered HMO for seniors built off the chassis of the Medicare program. And it's grown now to serve over 220,000 patients. We have about $3.5 billion in revenue, and we exist in 12 counties in California. What we're in the process of doing now is actually expanding to other geographies. So we're filing in states outside of California, and we're also in the process of diversifying to other ways of achieving our mission being to keep seniors independent and healthy. And so we're launching a home-based and virtual geriatric primary care medical group that's based on this concept of risk. We're launching a program for the all-inclusive care for the elderly, which is a different kind of model, which is focused on helping seniors age in place, that's built off of the Medicare and Medicaid programs. We're actually launching this homeless medical group. So we're busy, and we're also launching programs to address loneliness in the population of patients that we serve, recognizing that that's a secondary epidemic that I think has befallen the populations that we serve over the last year.
And so with that model and what you've built there, tell us about technology. How fundamental is technology, especially when you're talking about remote care, et cetera? How does that factor in?
So technology has the potential to revolutionize the care of patients of all ages. I think it can especially do so in the senior population. But one of the things that you have to realize is you have to meet people where they are. And I think oftentimes when I'm talking to a group of MBAs or medical students or residents, one of the big challenges is you can't actually imagine the lives of the people that we serve at Scan or we served at CareMore. When I was at CareMore, I led the first pilot with a ride-sharing company. In this case, it was working with Lyft to actually use ride-sharing to serve seniors. And I got together with a group of 250 of our seniors in a town hall. And I said, how many of you, this was 2017, how many of you have heard of Uber or Lyft? And no hands went up. No hands went up. And so oftentimes I think we understand what people need. But the truth is that we oftentimes don't understand how frail these populations are, how the literacy levels may vary, what information bubbles they may exist in. And so you actually have to meet people where they are. So Scan actually, in an initiative prompted by our CIO, Josh Good, actually introduced what we call a help desk benefit, which is seniors can literally call a help desk that we staff to ask questions about technology as it relates to their care, so that they can, many of them haven't set up an email address, which, as you know, is a requirement to get care in a virtual era. Many of them don't know how to turn on their computer. And so again, when you think about adopting and deploying technology to solve healthcare problems, you just have to realize that America is a 300 some odd million person country with very diverse populations, urban, rural, suburban, very different levels of health literacy and overall literacy. And if you're going to be an effective healthcare organization in a digital era, by all means, use digital tools and technologies, but you've got to meet people where they are. And the other thing I'll just say is, there's this thing that I think has befallen business schools, that this idea that's kind of permeated business schools, really prompted by one of my former professors, Regina Hertzlinger, which is this idea of consumer-driven healthcare, the idea that people just need to take control and take charge of their health. And I'm just going to ask you to think about a time in your life where you were really sick. And hopefully you haven't been this sick, but let's just say you were diagnosed with cancer or heart failure, or, you name it, you have a pneumonia that lands you in the hospital. How empowered do you really want to be when you're sick? And how much do you just really want the system to actually take care of you? And so our mental model of who patients are and what they need isn't, the Amazon user who's on an app and kind of searching for this or that. The better experience is when you get sick, the system just wraps around you and just delivers what you need and anticipates the needs that you didn't even know you had, and things just start to show up. And so, I think that we have to get the mental models right. One of the most kind of important lessons I learned when I was a political science student in undergrad is how you define the problem actually influences how you solve the problem. Yeah. And I think one of our biggest problems in healthcare is the problem definition. We sometimes focus on the things that people like us care about, the transaction friction, how hard it is to get an appointment. Those are all problems that we should work on solving. But the bigger problems are the business model problems, and the fact that we don't have the solutions we need to better manage people's diabetes or heart failure or COPD, and manage them upstream, because we don't pay for the system to do that.
So let me, with the risk of bringing up another HBS professor, maybe of yours or not, Clay Christensen, talked about disruptive innovation. And obviously there's some technology-based services that are very intuitive, that are lower priced, et cetera. The intuitive nature of an iPhone is an example, Google Maps, et cetera. The idea of better, cheaper, faster. Do you see opportunities for disruptive innovation in healthcare?
I absolutely do, but I think it's going to be about sticking to our knitting and focusing on the basics. And I actually think a lot of the work around consumer psychology has extraordinary applications, and consumer psychology as it relates to tech has extraordinary implications for how we think about preventing chronic disease and managing chronic disease. I'm a Fitbit user. And I can tell you, the interface on that device has gotten so much better over the last 8 or 10 years. Using the community aspects of it. I happened to be walking a lot during COVID. I got a text from a friend the other day saying, how come you've slowed down this week? You were doing so well the last few weeks. And I said, I'm busy. I have to go to this Innovate conference. And so, the idea is, I think there is more science that we have to kind of unlock from these other fields, that integrate technology. But at the end of the day, the emphasis needs to shift away from, the fancy pharma tech development to these lower tech solutions that frankly will keep people healthier longer. Nudge them in the direction of eating the right foods more, nudge them in the direction of exercising more. There's nothing less sexy than, as a physician, than telling your patient, you need to eat better and you need to actually, exercise more. What we really need is tools and technologies that actually, prompt that and actually support people in doing that and engage in healthier behaviors, more often than not. And so that's the work we have to do.
So I want to keep pressing on this disruptive piece to see how far I can push you before you say absolutely not. Yeah. If you look at our current students and assume that they're going to age into retired age at some point, and they're more digitally savvy, They're more used to buying on platform-based businesses. They're used to much more looking at data and information and decision-making. If you then take a company like Amazon, where you were talking about business models, like who has the incentive to see lower cost healthcare? I assume employers that are self-insured would fit in there. If you look at the capabilities of a company like Amazon, running a platform that runs super well, matching buyers, sellers, and if we could put in place healthcare providers and patients, the ability to manage in supply chain management, a completely vertically integrated solution in healthcare, the ability to use data, and then finally say, hey, listen, if they're able to create something for their own employees that's much better, why wouldn't they do what they did with AWS and say, listen, we've set up our own data centers. Now we're going to make this available to everybody. Do you see a scenario in the future? I'm not saying tomorrow, but in a few years from now, that would completely upend healthcare as we know it?
So the challenge of disrupting healthcare is that you actually are fundamentally reliant on the incumbents, even as you're trying to disrupt it. And there's probably no better case study of that. You mentioned Amazon, than Haven, which was, of course, the joint venture that existed between Amazon, Berkshire Hathaway, and JP Morgan Chase that recently unraveled itself, right? Mm-hmm. And the real postmortem on that is that if you're going to try to disrupt healthcare while you still rely on the same hospitals, the same dialysis service providers, the same pharmacies, you better build it all yourself if you're going to try to disrupt it. And the truth is you can't simultaneously take care of an employee population while also relying on it to disrupt it. I think there's a number of entities that have come up over the last number of years. I've been involved in leading, some of them around, kind of innovative primary care for specific populations. I think that fundamentally is an unsexy answer, but it is the answer. You need more confident generalists, more clinicians who can take care of a broader range of things and not farm everything out to specialists. People are incented to actually keep things in-house. And you need incentives in place that are going to keep people out of the hospital. And because that is the number one cost item. It's the one number, that I look at almost every single day is what is our bed days? How many patients are in the hospital? And what you want is that number to be lower, because every bed day in Southern California costs $3,500 to my bottom line. Every single day that a patient's in the hospital is $3,500. So when you think about how much prevention you can buy for $3,500 a day, over the large number of patients we take care of, you can buy a lot more prevention. And so that's the mentality that we have to adopt. And to your point, Terry, there's a number of tools and technologies. If you actually had a platform that did those things, you could actually, I think, make a lot of progress. The issue is, I think we always get the consumer model wrong. Who are the sickest patients today, Terry? Yeah. The sickest patients are older people with multiple comorbidities. Those are the folks you need to serve. And you need to make it absolutely simple and easy for them to use those services. Most of the solutions that exist out there haven't done that. You also need all the pieces to connect. They haven't connected. So if you're still using your primary care doc, you're still using your specialist, and they're all using different record systems, and they're not sharing data to a central place where it makes it easy to use, you're actually creating, a lot more complication for people than simplicity. I help my parents with their care. They live in the New York metropolitan area. They see specialists at all the different hospitals, in the area. They've got portals. They've got a different portal for every single hospital system. The data is incomplete in every single one of those portals. So the reality is the fragmentation in the real world then gets mimicked in the digital world. And as a result, you create this experience that's really lackluster. And so I actually think, the organizations that deliver the best experience to patients are the ones that are most integrated, where the plan is integrated with the healthcare delivery arm, and the digital tools and solutions that they're able to deploy to patients are more fulsome, because all of the data, and all of the providers are working seamlessly across all those systems. And right now we're too fragmented in healthcare.
Yeah. And on this topic about technology adoption, we'll dive deeper in a second, but is your message though that it's going to take longer for technology tools to be adopted in healthcare because of the uniqueness of the environment there?
I think it's this broken business model. It's this broken business model that ultimately doesn't reward folks for the implementation of tools and technology. Now, there's been some progress. There's been some fee-for-service codes that have been added for remote patient monitoring, for chronic care management. Those things are vastly, accelerating the adoption of technology. But what I can say is that, ultimately, the business model innovation is going to drive the technology innovation, and not vice versa. And I think for too long we've just hoped that well-intentioned, tech innovators would find in payers, well-intentioned folks who are going to sign checks for all the good stuff that they're doing. And unfortunately, that's just not how the world has worked in practice.
Interesting. So if we were to for a second say, the business model's got to change, and let's assume it does, if you were to look at the technology tools, which ones would you be most excited about? So as an example, we had David Feinberg a week or two ago, and it seems like they're going to develop the ability to create a diagnostic tool, a Google search engine for healthcare that I would think at some point could disrupt healthcare providers themselves, diagnosticians. Is that an area you say, hey, listen, that is going to be one of the highest leverage opportunities? Is it IoT, like your wearable devices for remote monitoring? What are the areas of technology innovation that you would say are the most exciting?
So this is really boring, but it's actually information, how information is stored, collected, and displayed to patients. Right now, most people with a high burden of chronic illness don't even know what diseases they have. They don't even know what those diseases mean. We need to make those things simpler. And so I actually think it's the information infrastructure. It's the connectivity between patients and the rest of the healthcare system. Those are going to be the infrastructural capabilities we need to build that are then going to allow you to do the sexier and more interesting IoT, Google-based tools. But right now, none of my doctor's offices, talk to each other. We don't really realize how fragmented, information flows are. And I think that there's been patches on the system. There's health information exchanges. There's that now, the FHIR API. I think we're moving in the right direction. But I would say, it's that basic stuff that I think ends up being the most impactful, sadly enough. We're still in the 1990s. Jim Malt, who leads, I think he's going to be here actually, right?
Tomorrow,
I think
yeah.
he used to say that we're sort of in the Quicken era, kind of online banking, where information is kind of entered into a log. It sits in your own kind of personal computer, but we haven't had the benefit of that information flowing across the system in ways that it makes it really easy to manage your finances. I still remember the days when you had actually kind of had to reconcile your own checkbook. You don't have to do that anymore, right? And so, I think we're still in that reconcile your own checkbook era. And so, the boring problems that need to be solved are, getting that information to flow in ways that it makes it easier for physicians to interface with patients, hospitals, and all the different pieces in the healthcare value chain.
Excellent.
Think about this COVID-19 vaccine. We're talking about technology solutions. How hard is it for this for the state of California, or any state for that matter, to actually do something as simple as create a vaccine registry and actually stab 2 doses of a vaccination into 300 million people? It's probably, it should be a really relatively easy thing to solve. The reason it's as difficult as it is we're as fragmented as we are. And and I think that that's the reality, is we need to create simpler, more integrated systems that are then going to make it easier for us to layer on the technology solutions that I think have all the promise that you're signaling. It's just that I think people don't realize how broken we are, where we need to fix things.
Yep. And let me ask you on that COVID issue, how do you think this is going to play out? And I would assume your patient population is one of the most worrisome with COVID. Where do you think this is going to go? How bad is the situation? Are you worried, et cetera, et cetera?
I'm super worried. I mean, I just got data about how many patients among the 220,000 seniors that we care for have had the vaccination. And, to the best of our knowledge, it's something like 700. We're in, late January. So here we are, and I used to work in pharma and biotech. Here we are, we developed a really high quality vaccine through very rigorous scientific methods over the course of a 6 or 7 month period. Mm-hmm. So the science is extraordinary and the scientific development capabilities of this country are extraordinary. What's missing is the healthcare delivery capabilities, right? Mm-hmm. And what we're showing is that the US is #1 in the world in scientific innovation, and we're God knows where, as far as our delivery capabilities. Yeah. And so that's what we need to fix is that infrastructure piece.
Yeah. So is this a fundamental failure of leadership, that the COVID situation we're in, the inability to plan, the inability to use data, the inability to understand the end user, the inability to have a model that's more integrated, to your point, is this a fundamental leadership failure?
It's absolutely a leadership failure. I don't want to get into politics because I don't think it's helpful. But I think that leadership at the end of the day is the thing that's going to solve all of our healthcare problems. And the reason I say that is because people talk about these new payment models like, they were being invented as, new technologies. They were actually started in California. They've been around for decades. We know that they work. We know that there's federal programs that make it easier for provider organizations to actually participate in these new payment models. Mm-hmm. But the change leadership that's required to shift an organization from a mindset of we get paid more to do more stuff to we do better when our patients do better is not something that anyone has taken on. CEOs of healthcare organizations haven't taken it on. Boards haven't taken it on because what we're fundamentally arguing for is a contraction of the business model, right? Mm-hmm. What a better healthcare system would look like is fewer hospital beds and more outpatient clinics. Mm-hmm. And that's a weird message to deliver to people who've spent the last 30 or 40 years building new towers and building more hospital beds, because that's what success looked like. And so we do need a crop of leaders in this country who are willing to have the hard conversations with their boards and their management teams and say, we're getting smaller, not bigger. That's a strange message. That's a strange message to deliver.
Tough one. It's a tough one, but you're serving a community, a nation, et cetera, in adopting that.
Yeah, if you're a nonprofit CEO in healthcare and you lead a large healthcare system, your stated mission should be to lower your revenues and increase your margins. That's a very that's a very different message than every other kind of health organization in the world where you're looking to grow your revenues and grow your margins. But in healthcare, if you're shrinking your revenues, you're doing a better job of keeping the community healthy. Or you have to say that you're going to be raising your risk-based revenues and then increasing your margin because people aren't using healthcare services as much. That's a different mindset.
Mm-hmm. We've got a whole bunch of questions. I want to start going through all of them here. So Katie and quite a few others who upvoted it asked the question, in addition to value-based care, how do we address lack of price transparency and consumer choice in healthcare?
The reality is that there's a lot of technology innovation that's going on around this issue of, kind of price transparency, but it's been going on for 20 years and it hasn't gotten us there. And again, I think it goes back to leadership again. I think healthcare organizations that are going to win in 2021, new year that we're in, 2021, are going to be the ones that say, we're going to give you the bottom line price for what you're doing, and we're going to pre-adjudicate the claim with your health insurance company, and you're going to know exactly what it's going to cost you to get your services. Unfortunately, the reason that we haven't gotten there is because we've locked people into, this world where, that's not the expectation or the norm. And so I think organizations that get there first are going to be more attractive to patients for sure.
Does this question kind of go to the point about Amazon, the Amazon model of a platform, transparencies, ratings, price comparison, all that?
It does, but the problem with the Amazon analogy is that, and this is where, some knowledge of clinical medicine actually helps, is like a diabetic is not a diabetic is not a diabetic, right? And so the services that a diabetic needs are going to vary pretty dramatically based on, you know, where they are in their disease trajectory. And so, you know, a lot of times this fixed price model, you know, I would say it's much more like taking your car to a mechanic, and Amazon hasn't solved that problem, right? Because there's a lack of you know, transparency to the end user on what's actually happening with them. Yeah. And the only way you can actually know is you can go to 3 different mechanics, and the 3 different mechanics may tell you 3 different things. And the truth, because there's a lot of art and science to medicine, is actually somewhere in between. And so I think people tend to think of healthcare as being far more science than it is art. And the reality is that we have a lot of evidence about what works in a lot of situations, and then we have a lot of good guesses in other situations. And there's probably no better, you know, demonstration of that than you know, how we managed COVID in the first innings of this pandemic, which is, you know, we tried steroids, we tried hydroxychloroquine, we tried remdesivir. Oh, wait a minute, that worked. Okay, then we thought about antibodies. And the truth is that a lot of healthcare is trial and error. And what works for me isn't what's going to be what works for you. Metformin may be perfect to manage your early stage diabetes. Januvia may be what I need, because I don't do well on metformin. I developed, you know, some cramps on it. So the idea that you're going to have this like fixed price, you know, ignores the heterogeneity of the end user and the customer. And again, this goes back to the mental model problem that I think we oftentimes have. Getting healthcare is not like, buying your groceries online. It's much more like taking your car to a mechanic.
Yeah, but is there an 80-20 rule though on medical procedures that a disruptor would say, listen, I understand there's a whole bunch of complex procedures, but I'm going to focus on the bottom when somebody has a cold or they bang their finger and they don't know if it's broken or not, and you can actually more easily make a determination, and that will be the areas that we see the innovation around.
Yeah, and I think Minute Clinic has done that, right? So Minute Clinic, if you actually study the history of that business, which is really an interesting history, picked 12 conditions. They said we're going to really manage colds better, and we're going to create these real boundary conditions that if you have these 12 conditions, we're going to manage them here, and if you have anything else, it's going to go somewhere else. Mm-hmm. Well, guess what? All the empirical studies of Minute Clinic show that it actually increases healthcare costs, doesn't decrease it, because when you carve out something to be managed in one place, but aren't going to manage the other things, then all of a sudden you've created 2 visits, not 1. And that is the part of the problem. When you start to try to oversimplify stuff and abstract the complexity, it looks clean. It creates a cleaner customer experience. You just haven't solved the problem. Because Terry, guess what? You had a cold, but you also had, an exacerbation of your congestive heart failure, and they don't want to help you with the heart failure. They're going to send you to the emergency room for that, but they're going to give you that cold pack that's going to help them sell, whatever from their over-the-counter pharmacy. So, these are the real life applications of how these problems are more complex, than I think they are simple.
Sachin, I have to say, I'm getting more worried about the state of affairs of healthcare than I was 45 minutes ago.
I'm sorry. This is hard business, but this is where, again, I think it's about leadership. It's about entrepreneurship. I think, and I think it's about, principled leadership and asking these hard questions that I think we stopped asking a long time ago, Terry, which is, why do we make more money, when people are sicker, and why are all these businesses built on that platform? And how do we, create a generation of entrepreneurs who are moving the needle, completely in the other direction.
Yeah. And I think you're basically saying the problems are big, they're complex, there's massive upside, but it's going to take fundamental business model reform. And in the interim, we'll get a bunch of good incremental improvements that are needed.
But it's not putting a man on the moon. It's not developing a COVID-19 vaccination. And that's the thing, right? This is a thing where the answers are actually relatively self-evident. The issue is the organizational sociology and kind of the physics of healthcare finance. That's not rocket science, right? That is a solvable problem. But without outing lots of kind of well-meaning organizations, a lot of well-meaning organizations out there don't want to make these changes. They don't want to make these shifts, and as a result, they're on this fee-for-service treadmill of do more to get paid more. And that's why you have overutilization of healthcare procedures. It's why, Terry, when you show up with, a little bit of chest pain that may be muscle strain, you probably will end up with a cardiac catheterization instead of, the ice pack that the situation probably deserves.
Yeah, fascinating, fascinating. Another question, a lot of people upvoting it. How does personal responsibility for healthy behaviors enter into the shift in approach to healthcare? For example, incentives for patients, not only for providers.
So I think that incentives for patients are interesting. There's been a lot of great health services research in this space done by people, behavioral economists like Kevin Volpe and Amol Navathe at the University of Pennsylvania. At the end of the day, you have to think about the kind of world that you want to live in, right? And the kind of world that you want to get care in. Mm-hmm. And the truth is that a world-class consumer experience is going to be one that doesn't quote unquote expect you to do the right things. It's going to actually enable you and nudge you and motivate you to do the right things. And that's not to say that people shouldn't have personal experience for personal responsibility for doing things, but we live in a weird world where people have very different starting points in different circumstances, and where ultimately I believe there is a healthcare system out there that will over time create the right environmental conditions, the right education, the right nudges to actually have the right things happen for people more often than not. The idea that you're going to take people with variable literacy levels, okay, they're in the real world, who don't necessarily understand, the difference between a randomized controlled trial and an intent to treat analysis. And I would challenge 500 Anderson MBAs if they can actually tell me the difference between the two. And then be able to, ask them to take personal responsibility to process the information to then make a good choice is actually a lot, right? And there are these consumer experiences where it's more important to trust expertise and professionals to do the right thing for you because they are as complex as they are, rather than forcing people to take personal responsibility at every step of the way. And so, the way I think about it is, if we're going to follow this car analogy again, you want people to drive responsibly. Responsibly. But when their car breaks down, you want them to have some sort of coverage or protection so that things just get taken care of and they get back on the road. And maybe if they're driving irresponsibly, you charge them a little bit more on their rates. But at the end of the day, they still have coverage because we as a society have decided that we believe that insurance and social insurance is an important part of the fabric of a just society. That's kind of how I think about it.
Yep. Makes sense. Another question, Danielle. She said medical students are highly incentivized to be specialists since family medicine and primary care physicians are paid much less. How do you see this changing?
So I think this is about this business model innovation. And I will tell you, there are primary care doctors here in Southern California who make between $500,000 and $1 million a year because they've understood how to, get risk-based contracts, manage a population really well, keep patients out of the hospital, be available to them 24/7. And when patients are kept out of the hospital, because they're in risk-based payment agreements, they actually, see more revenue from that. They see savings from that ends up flowing to their bottom line. And so again, I think we have to have diffusion of these business models so that more people can do those kinds of specialties and be rewarded for actually keeping patients healthier and well. That's a big part of why we're building a geriatrics business at SCAN. Is geriatrics is one of these specialties where you actually train more to get paid less, but ultimately it creates a lot of value for the healthcare system. If we can build a value-based geriatrics medical group that scales nationally, we can create a place where people can come and do really, really well financially, provided they do right by patients and keep them out of the hospital and keep them well.
Excellent. Let me ask you a last question before we do a summary here. Krishna says, so would you say in future integrated models like Kaiser Permanente, where health plan and delivery are together, will be more successful than others?
I know that they are. When you look at kind of the objective metrics of performance, and the Medicare star ratings is a really good system of evaluating many dimensions of clinical quality, not all dimensions of clinical quality, but includes patient experience measures, it includes preventative care measures. Kaiser is consistently a 5-star organization, and they're very hard to chase. Because SCAN is a 4.5-star organization, Kaiser is a 5-star organization. They're very hard to chase in some ways because the right hand does speak to the left, and there is that level of integration. And frankly, information flows at Kaiser. When you have something done to you at Kaiser, the whole system knows about it. And I think that is a unique differentiator. A lot of delivering great healthcare is information management. I don't think people really know that to the extent that they should. There's a lot of avoided duplication in services if you actually have a central repository of information. And so, again, I think, integration or virtual, either real or virtually integrated care is the future, and it's what we need more of.
Excellent. Sachin, let me do a shot. I always, at the end of these, try and summarize what I heard you say, and I want to give you a chance to either upgrade or share your own parting comments.
Sure.
So I got 5 or 6 key points from you. The first one, actually at the very beginning, is advice to everybody about taking risks, and don't get a kind of a monolithic view of who you are and your capabilities and what you can do. That's the first thing I took away. Second thing, major point about business model innovation. For everything we talk about technology-based innovation, in this case, the fundamental kind of piece is you better reform the business model, or all these other things are not going to feel very satisfying. A third point that I took away is this idea of consumer or patient adoption. COVID-19, you said, basically took 30 years of progress and jammed it into 6 months. So this kind of sense of urgency can happen, and we can see discontinuities of adoption and innovation occur. Fourth point I got is know the customer, which sounds basic, but a lot of what you're saying is we think we know the customer, and we do a lot of development and innovation and all that, and we end up missing the mark. And your example of people that might be elderly that have never used Lyft and don't know what it is, et cetera. A fifth point is the challenge of innovation when you're reliant on incumbents, and how strong the incumbents are makes the disruption issue fairly difficult. And in this case, it may be one of the more pronounced ones. Sixth item, I think I'm on the sixth item. Fragmentation is a problem. In any organization, in any nation, et cetera, you have to look at what are the diseconomies of scale and standardization against kind of the benefits of individual laissez-faire entrepreneurship. We've tilted a bit too much, especially in healthcare, on fragmentation, and we've got to standardize things more. And then the final message, which is apt, I think, to the whole conference, is you said leadership is fundamentally what's created the problems in healthcare and what is going to be necessary for the improvements. And leadership in the most noble sense, which is a more selfless as well as data-oriented, strategic, customer-minded effort. Those are the 5 or 6 points I took away. Any upgrades, anything?
Yeah, no, I'll just, kind of underscore the leadership point again. I mean, when I kind of think about what's going to fix American healthcare, what's going to change it for the better, sustainably, it's going to be leadership. And I think absent that leadership, we're going to stay on this treadmill that we've been on for as long as we have, doing the same things and expecting different results. If we want to get different results, we have to start doing different things. And that's going to require folks with the will and skill to change direction, to change course. And that's not easy. And that's not, for the feeble or for the weak. It's for strong leaders. So, when I was in business school, I remember, people saying, oh, it's going to be the change management and leadership and organizational behavior classes that are going to be the most memorable and most important to your career. And I was like, yeah, sure. No, I'm sure that's true. It was, and I wish I took more. I mean, absolutely, like that is, I think, where the rubber meets the road.
Yeah. What a great set of messages, Sachin. I just wanted to thank you because I think you highlighted a lot of challenges in this area. And when I was a bit joking with you that this is all sounding pretty dire, you also are saying there's some really big opportunities here. and they will create better outcomes, but you need the leadership. This is the essence of the word leadership. So I just want to thank you because you've really kind of raised the bar on what we talk about with innovation, and it isn't just technology, it's in a lot of other areas. So a big thank you. By the way, we're going to go to the breakout groups. Sachin is going to be randomly going around the breakout groups, and thank you for your time with us, and we'll look forward to having you back again very soon.
An honor to be here. Thanks so much, Terry.
Good deal. Thank you.
All right. Bye-bye.